Hello, my name is Dr. Catherine DeUgarte. I work at Pacific Fertility Center, and today we're going to discuss in vitro fertilization. IVF has been around since 1978, since Louise Brown was first born out of many experiments in London. In terms of IVF, it's now used by hundreds, if not thousands, of couples every day in the world. And the US happens to be one of the best places to do IVF because the success rates are one of the highest in the world. In terms of who needs IVF, are patients who have severe male factor infertility, such as very low sperm counts, women who have diminished ovarian reserve or low ovarian reserve, women who have genetic conditions or couples who have genetic conditions that they're not compatible with in terms of, for example, recessive disorders that we can select the normal ones. Patients who, for example, have breast cancer and don't want their kids to have the breast cancer gene can choose sometimes to do IVF. Women who have a history of ectopic pregnancy or other issues that have caused their fallopian tubes to be damaged, absent, or surgically removed are sometimes needing in vitro fertilization because the egg and the sperm can't meet in them. So they must do IVF in order to get pregnant. In terms of other indications for IVF are same-sex couples, for example, two men who need to have a baby, need to get an egg donor and a surrogate, and so they need the IVF process to have a baby, as well as other patients who want to freeze their embryos for the future. So for example, some couples would like to have a baby in 3-4 years from now, but they don't want to advance in age, and so they would like to freeze their embryos now when their eggs and sperm are younger. So a lot of people go to IVF to freeze embryos for future use. So let's talk a little bit about IVF. How long does it take? Do I need to do it? What can I do to improve the chances? In terms of what can I do to improve the chances, I am a big believer in lifestyle and eating healthy, not drinking alcohol, not doing pot, not smoking for 3 months before doing the IVF process if possible. If, God forbid, you get diagnosed with cancer and you have to do IVF as soon as possible, obviously you don't have the luxury of waiting 3 months. But if you have the option of improving your fertility and increasing the number of eggs that you get by IVF, I think it's a good idea to decrease stress. The way you can do that is by doing acupuncture, decreasing the amount of work that you do, saying no to things you don't want to go to, for example, family gatherings that you really don't want to go to, that's going to cause a lot of stress. I usually recommend not going to. In terms of other things you can do to improve chances of IVF, I do recommend a Mediterranean diet, eating lots of grains, fruits, vegetables, avoiding processed foods, decreasing carbs and increasing protein. I think that always helps in terms of improving chances of a successful IVF cycle. In terms of doing acupuncture, there are some studies that show that acupuncture can improve IVF success rate. It can increase blood flow to the ovaries. It can increase blood flow to the uterus at the time of the transfer. And it can decrease the stress, which can then also increase the number of eggs. In terms of IVF protocols, every doctor believes in different protocols. Some doctors do different protocols for different patients. Some patients try one protocol which doesn't work, and then you have to switch to a different protocol. But there's usually about 5 protocols that doctors use. Some are called minimal stimulation protocols, which involve less medications. Some are higher protocols, higher medication protocols, which involve more shots per day. And some doctors recommend birth control pills versus no birth control pills. It's very controversial whether birth control pills can help or hurt or not make a difference in IVF success rate. Some doctors use birth control pills for timing. For example, if somebody has a very busy lifestyle, let's say it's a physician that can only do the IVF cycle this 1 week when they're on vacation, then we do birth control pills to time it perfectly for that week when they're available. In terms of how long does an IVF process take? If you're not doing birth control pills, you call with your period. You come in on the second day of your period. We do an ultrasound and possible blood test to see how many follicles you have and make sure there's no ovarian cysts. We teach you how to do the medications, and then the medications are in the form of shots. So usually do 2 to 3 shots per day for about 10 days. And during that time, we do ultrasounds to see how many eggs you're making. the more eggs, the better. And then when you get to a certain point, we do something called a trigger shot. And the trigger shot makes you ovulate into the follicular fluid, which is in the ovaries. And so the day of the egg retrieval, you get anesthesia, IV. We put you to sleep. And while you're asleep, we do an egg retrieval. So what we do during that time is, if this is your uterus and these are your ovaries, we put a needle directly into the ovaries. We get the eggs out and we give them to the IVF lab. And the IVF lab at that point takes every single one egg, counts them, looks at them, sees if they're mature or not, and then puts them in a special culture dish. Once that is done, if you're freezing eggs, we put them as eggs in the freezer. If you're freezing embryos and doing IVF, we use the sperm to either put the sperm around the eggs or directly into the eggs by a process called intracytoplasmic sperm injection. And over here, you can see that, for example, in this patient, let's say we took out 14 eggs. And I know these are chocolate eggs, but let's assume they're real eggs. And so in this patient, let's say we took out 14 eggs, and we don't know if they're good eggs or bad eggs until we actually look at them under the microscope. So once we look under the microscope, let's say 12 of them are mature, so the others go away. And then we put sperm either around the eggs or into the eggs to let them fertilize. We then check them the next day. We do a fertilization check where we check to see if the egg has now become an embryo. And we look for something called 2p end stage. They have to have 2 little pronuclei. Once we look, about 80% of the ICSI ones and about 65% of the IVF ones fertilize. And so if we're looking at our pool of eggs here, we've lost a few because not all of them have fertilized. And then we keep them in a culture until we get them to day 3 and day 5, 6, or 7, till we get to the blastocyst stage. During this time, along the way, we're going to lose more eggs by the time we get to day 3, and we're going to lose more eggs by the time we get to day 5. And so, for example, by the time we get to the blastocyst stage, we might be down to just 4 embryos. So at that point, you can either decide to do a fresh transfer, where we put 1 embryo directly into the uterus. And this is something that we used to do when I was first a fellow about 20 years ago. We used to do fresh transfers on everybody. But since then, the technology has gotten better and frozen embryo transfers are now more successful. The other reason we do frozen embryo transfers is that we can also do genetic testing or pre-implantation genetic testing on the embryos to see which ones are normal or abnormal, which ones have chromosomal abnormalities that would cause a miscarriage, abnormal babies, or just not work. So the way we do that is we take these blasts that have arrived to the blastocyst stage on day 5. We do a little biopsy on them. We take a few cells out and send that out for genetic testing. And then depending on the person's age and history, the percentage of normal embryos that we get, we don't know for about 2 weeks. So in 2 weeks, we call you with results. And for example, if you have 4 embryos that made it, the green ones are abnormal, they go away, and so you're down to a boy and a girl, 2 normals from all those 14 eggs that you started with. And so I usually tell my patients that if you start out with a certain number of eggs, by the time you fertilize, you're like half as many. By the time you make it to day 3, it's another half. By the time you make it to day 5, it's another half of the half that make it, and then again another half to be normal. So the more eggs you start with, the better. Now, I've had patients who end up with 1 egg starting with, and they ended up with 1 normal baby. And I've had patients who start out with 20 eggs and end up with no normal. So it kind of depends on the person. And again, the younger the person is, the more chances of normal embryos. So that's the process and the outcome. So how many embryos should you have for a baby? So I usually recommend 2 normal embryos per baby. So if somebody wants 5 kids, ideally you should have 10 embryos frozen. If somebody wants 2 kids, then 2 embryos would be great. However, if 1 doesn't work and you're 42, it's going to be harder to get pregnant at that point. So it would be good to save 2 embryos for your baby number 2 and then get pregnant now naturally, let's say you're 38, or do another IVF cycle to freeze more embryos for the future. So again, 2 normal embryos per baby is what I recommend. In terms of the IVF process itself, you take fertility medications for about 2 weeks, and afterwards, I don't recommend doing exercise or having sex during that process as well as afterwards, because you can end up twisting your ovaries. So if your ovaries get very big, you can end up twisting them, and you could have something called ovarian torsion, which can end up in an emergency and potentially losing your ovary. That is very rare. In terms of the risks of doing IVF, the medications risks, breast tenderness, moodiness, headaches, sleepiness, in terms of bloating, in terms of hyperstimulation syndrome, where your ovaries get very enlarged. That's very rare. Less than 1% of patients get that. In terms of risks of the actual egg retrieval, where we take the eggs out, there's risk of bleeding, which is very rare, risk of infection, which is rare, we give antibiotics, damage to other organs, and anesthesia risks. In terms of should you do genetic testing, if you have a genetic condition and both the members of the couple are a carrier for the same condition, for example, cystic fibrosis, you can prevent the baby from having it by doing PGTM, which is pre-implantation genetic testing, monosomy. However, most people don't have the same mutations, and so we do something called PGTA, or pre-implantation genetic testing aneuploidy, where we can check for the normal embryos. This is an optional addition to the IVF process. Not everybody does it, but again, it gives you a lot of information and it prevents future miscarriages. In terms of once you have the embryos, how do you get pregnant with them? How do you do an embryo transfer? So there's multiple ways to do a transfer. You can do something called a natural transfer, where you call us with your period, and then we see when you're ovulating, and then 5 days after ovulation, we put an embryo directly into the uterus, and that's called a natural cycle ovulation. You can do a modified natural, where you take fertility medications for a few days, and then we trigger ovulation, and we do, again, the transfer of one embryo 5 days after ovulation. However, if you're having intercourse, you have to be careful not to get pregnant with that egg that ovulates, because what if you get pregnant with two? One that ovulates and one that you put in, you could end up with twins, or you could end up with one abnormal baby and one normal baby, because the one that you ovulate is not genetically tested. So that's natural protocol versus modified natural. Most people do something called a medicated FET cycle, where you take estrogen pills, and then you can take progesterone, either vaginal shots or combination, where we prepare your uterus so that the lining is very receptive to that embryo, so that it implants when you put the embryo in. So you usually do 3 weeks of estrogen, and then you do progesterone for about 6 days, and then we put the embryo directly into the uterus on the 6th or 7th day of the progesterone, depending on your history and depending on what's needed. In terms of a mock cycle, some patients ask me about mock cycle. It's very controversial whether people should be doing a mock cycle. Some people decide, for example, if they have one normal embryo and they've had cancer and they can't produce any new eggs, and they have that one golden embryo that they just want to have the highest chance of getting pregnant, they do a process called a mock cycle, where we do an endometrial biopsy, which is a little painful and not always covered by insurance, where we take a little catheter that looks like this, and we put it directly into the uterus, and then we take some cells out from the uterine lining, and then we send that tissue out for 2 different tests. One is called the endometrial receptive assay trio, the ERA trio, and the other one's called the Receptiva test. The ERA trio checks for 3 different tests. It checks for the endometrial receptive assay, which checks to guide us to tell us which day of progesterone should we do the transfer. Should we do the transfer on the 6th day of progesterone or the 7th day? It gives us exactly how many hours before the time of starting progesterone and doing the transfer. That's the ERA test. The EMA test checks for probiotics to see if you need to have probiotics before doing a transfer. And then it also checks for abnormal bacteria. The ALICE test also checks for bacteria, see if you need antibiotics before you do a transfer. And the last test is the Receptiva, which checks for polyps, cancer, and a BCL6 protein, which is associated with endometriosis. If you have BCL6 positive Receptiva test, then you need to take Lupron for 2 months beforehand, as well as 2 other medications to increase the chance of transfer working. So that's called the mock cycle. So I talk to my patients about needing a mock cycle or not, depending on how many normal embryos they want, and in terms of family planning, how many babies they want. If they have 10 normal embryos, I don't think think they need to do a mock cycle. Again, if they have one normal embryo and they can't get any more new embryos, then I think it's a good idea. If you have any more questions about IVF or any other fertility questions, please call me at Pacific Fertility Center. Thank you.